I am very pleased today to have two excellent speakers. Dr. Vikas Gupta, Director, MMS Medical Affairs at Becton, Dickinson and Company, and Dr. Kalvin Yu, Vice President, Medical and Scientific Affairs, U.S. Region. Prior to being at BD, Dr. Yu was Chief of Infectious Diseases at Southern California Kaiser Permanente. They will present on insights from near real-time data on infection rates and related outcomes in the post-COVID-19 vaccine period. They will also give insights into patterns of rising bacterial resistance that they have observed during this time period. At this time, I will turn the floor over to Dr. Gupta.
Thank you, Kevin, and I appreciate the opportunity to present on insights that we've gleaned from our data set. What we'll be doing today is reviewing bacterial infection trends during and prior to the COVID-19 pandemic in the U.S. and provide a clinical summary in conclusion. But before we dive into the data, a little background on our data set. So the BD Insights data set receives near real-time data feeds from participating institutions. The near real-time data feeds include a laboratory information system feed. Thereby, we get all the laboratory results in both the inpatient and outpatient settings, as well as the microbiology results from which we've gleaned insights that we're going to be sharing. We also received an inpatient pharmacy information system order feed as well as patient movement data, the admission, discharge, transfer data. All that data comes into our data set. We link it at a patient level that is de-identified. But what's unique is also that we normalize the data to a common standard. What that allows us to do is what's on the right, doing geospatial mapping of pathogens, including COVID-19 across the U.S. We were able to look at incidence, prevalence, and severity of care, look at burden of disease by patient demographics. We'll be sharing some of this data, co-infections and severity of illness of admissions and why that's important. We've also been able to glean medication utilization signals as well as we look at our data on an ongoing basis, and then look at trends and correlations of outcomes data as well. So again, all this data is coming in near real time. It's normalized to a common standard and allows us to evaluate this data on an ongoing basis. But before we dive into the data looking at results during the COVID pandemic period, we did some initial analyses to see what does the data look like with other viruses. So here what we wanted to do what we did is looked at evaluating antimicrobial resistance with influenza. So in the graphs on the right, what you'll see is the blue lines indicating influenza positive admissions. And you can see the peaks and valleys that we see occurring during normal or common influenza seasons. And the orange lines are representing antimicrobial resistance rates. These are data that are evaluated quarterly from 2011 through 2019 across approximately 257 institutions. And what our findings found was an increase in rates of antimicrobial resistance in gram-positive pathogens. Strep pneumonia, as an example, would be expected, common respiratory pathogen. But what was surprising is we saw small but surprising increases in antimicrobial resistance among gram-negative pathogens associated with influenza activity, and that is on the right side that you see. So this kind of gave us some signals, and we, as clinicians, I think Kalvin and I would see some of these when we were practicing. But what are the implications of this during the COVID-19 pandemic, especially in flu cases? We did a further evaluation to look at inpatient antimicrobial use. And what we found is that a significant correlation with influenza and inpatient antibiotic use. So on the right side, again, the blue line indicating influenza positive rates fluctuating over time from 2015 to 2019. This is approximately 230 plus institutions. And you see the lines indicating antimicrobial usage. So we evaluated macrolides, extended spectrum cephalosporins, tetracyclines, fluoroquinolones, glycopeptides, and lipopeptides. And what we found is an increase in inpatient antibiotic use for extended spectrum cephalosporins and beta-lactamase inhibitor combination. Those classes were increasing overall. What we found is extended spectrum cephalosporins and macrolide use was strongly correlated with influenza season. So again, monitoring influenza signals from this analysis we found may provide some more insights that can inform interpretation of inpatient antibiotic use trends, and maybe incorporated into antimicrobial stewardship programs as well. So how does this translate to the COVID-19 pandemic? And what we found is, in the graph on the right that you see, especially with those elongated circles, are the three recent waves of COVID. So the 2022 wave is the Omicron wave, the middle circle is the Delta wave, and then the winter wave from the 2021 surge that we saw. And you can see here that we're also seeing fluctuations in use of certain medications on the inpatient side. So you can see this beige line here is representing corticosteroids, and you see corticosteroid use increasing during these peaks. But we're also seeing increases in third-generation cephalosporin use and other antibiotics as well. So rising medication use during COVID-19 surges can provide early signals for severity. More recently, as we've seen number of admissions for COVID-19 decrease, we're actually seeing much less corticosteroid use in the more recent time period. Other signals that we're able to pick up and can be picked up by using near real-time data, especially looking at laboratory signals, is evaluation of disease severity. Now, this is something that we were evaluating during the recent Omicron wave, and what we found, and you'll see on the graph on the left, on the top you see the different organ dysfunctions that we evaluated during the admission period, everything from kidney dysfunction to liver dysfunction, etc. The green line here indicates none of those clinical conditions. And what we saw as hospitals would see a surge, you see a decline in the number associated with no clinical condition. And we saw this consistently with the three surges represented with the red arrows here. But what was interesting is the most recent surge, the Omicron surge, that nadir was higher than what we saw with the Delta surge in the winter 2021 surge. And so that kind of gave us a signal that are we seeing less severity potentially in the most recent surge. We actually collaborated with the CDC, and on the right you see table 2 from a study that was published in MMWR using our data. And rather than walking through each of the different data points, what we found is those patients that were hospitalized during the Omicron or the most recent surge had age distributions that were different compared to Delta in the winter 2021, less likely to be hospitalized in the intensive care unit, have a lower hospital death, and also require less mechanical ventilation. So again, these type of signals, continuing to monitor, can provide very important and interesting insights going beyond hospitalization rates for COVID-positive admissions. So with that, what I'd like to do is hand it over to Dr. Yu, who will review the infection insight data and microbiology data.
Thanks, Vikas, and thanks, Kevin, for inviting us to present today with your group. So the insights from here on in are more from what a hospital administrator might do or public health insights, and sort of the importance of having this type of data in near real time to help inform whether it's public policy or hospital policy. So continuing on with the analysis that Vikas was giving line of sight to, we looked at bloodstream infections during the COVID pandemic, and we noted that both community onset and hospital onset bloodstream infections were more common during the pandemic. And retrospectively, we know that because of the surge capacity that most of the COVID waves produced, that the infection prevention bundles that we know, those of us that deal with that in healthcare since they went live in early 2000s, that when it comes to a nursing ratio that's increased from 1:4 to 1:6, as an example, or rounding from 15 patients to 25 patients a day, that those bundle elements tend to fall apart. And so we saw more CLABSI and more CAUTI. And that was not only codified by us, we published one of the first papers on that, but follow-up papers from the CDC and academic institutions like Johns Hopkins. And so having visibility, bloodstream infections do actually increase during a pandemic, whether it's because of operational workflow issues or, in the case of Delta, perhaps more severe illness. It is important because that can help set the tone on what public policy is and why we might need it. And we also saw that there was an increase in bloodstream infection risk with increasing length of stay. Now, this is a known medical fact. If you have someone has a prolonged hospital stay and in the ICU, they're at higher risk for a hospital-acquired bloodstream infection, perhaps. But knowing this in the middle of a pandemic and having these insights of both community onset bloodstream infection was new and new information. We also looked at outcomes from community onset. And by the way, community onset we defined as traditionally as reportable hospital-acquired designations by the NHSN as a culture that was collected within the first 48 hours of admission. And then hospital onset respiratory infections. And we saw that these outcomes were worse in COVID patients. And more importantly, we saw differences in the pathogen types. Gram-positive pathogens like Staph aureus or strep species were more common in SARS-CoV-2 positive patients. And the mortality as well was 2 times higher in SARS-CoV-2 positive patients. And so this has impact on the importance of empiric antimicrobial prescribing. So there's always this balance now, especially since the CMS codified the requirement as a condition of participation for antimicrobial stewardship programs to be in a hospital that bills CMS. And so there's this balance between going broad for empiric antimicrobials and doing just enough to get what ultimately grows out. And so for a respiratory virus in particular, and we see a version of this with influenza over the last few decades, is that there is an overuse of antimicrobials. When you see someone that has a fever and a cough and a whiteout on the chest x-ray, of course you're going to give antibiotics. But at the end of the day, when we looked at the data, the rate of co-infection of SARS-CoV-2 and either a bacterial or a fungal co-pathogen is relatively low. And so that balance is what clinicians need to be aware of when they're prescribing empiric therapy. And this is where information like this at the patient encounter level can be helpful to guide clinicians. We also took a look at antimicrobial resistance rates and found that they were higher in the hospital onset period throughout the COVID pandemic. And so overall, the antimicrobial resistance rates were lower in the pandemic period compared to the pre-pandemic period. But again, if you look at that important cutoff period, if you look at just the hospital onset period, because ostensibly when you're thinking about COVID, they are coming in probably not with a bacterial co-infection right off the bat. They're probably acquiring that because they're staying in the hospital stay longer, or they're sicker, like we saw with the Delta strain, and requiring more invasive devices and then getting secondary bacterial or fungal infections. And so when we look at the data with that time frame of hospital onset further, which is day 3 of admission or higher, the antimicrobial resistance rates were actually significantly higher overall in the pandemic period, especially in SARS-CoV-2 positive patients. And so this has implications on a couple of questions that we still don't have answers to. Does acute prescribing of inpatient antimicrobials influence acute antimicrobial resistance trends? Looks like it does so far in the pandemic, but if so, does it influence long-term antimicrobial resistance, which is really the big question here, because antimicrobial resistance was the great pandemic that no one was talking about before COVID. And so if COVID sticks around like we think it does, and antimicrobial prescribing patterns don't change, what is the added effect of this additional increase in very broad antimicrobials due to the overall picture of antimicrobial resistance, which was already a problem before COVID came along? And then more importantly, this new X factor of CMS requiring antimicrobial stewardship teams, what can they do to influence either? And so we have some insights on some possibilities. So what can stewardship teams influence? We looked at adequate and inadequate empiric therapy during the pandemic, and inadequate empiric therapy was actually associated with higher length of stay and mortality in SARS-CoV-2 patients. And keep in mind, empiric therapy, for those of you who might be listening to this on social media and are not in the healthcare realm, empiric therapy is the antibiotics that we clinicians use when we see someone that's sick, but none of the diagnostic tests have come back yet, and we don't necessarily know what is the infecting pathogen. Or we just know we're in the middle of a pandemic, they have respiratory symptoms and a fever. We talked to their family member and they had COVID just 5 days ago. You could make a safe bet that probably they have at least SARS-CoV-2, but do they have something else? And so that empiric therapy is done blind essentially. And so when it's inadequate, when it doesn't actually cover that secondary bacteria or secondary fungal infection that eventually grows out later in the hospitalization, that's when you see this discrepancy of higher length of stay and higher mortality. So we do know that from these studies, bacterial pathogens continue to play an important role in hospital outcomes during the pandemic, and adequate and timely therapeutic management may help ensure better outcomes. And we had a little discussion on what diagnostic stewardship means. In general, these are the central tenets of diagnostic stewardship. Get in your diagnostic test, find out what the patient has and what they likely have, marry that with your physical exam, your imaging studies, the other blood tests like a white blood cell count, et cetera, and then pare down your antimicrobials from your empiric to your definitive based on your clinical judgment. And that is essentially what diagnostic stewardship does, and it's married very closely to antimicrobial stewardship. And so taking a step back and looking at the bigger picture, we looked at inadequate empiric therapy before the pandemic and then during, and then juxtaposed those two timeframes. And overall, inappropriate or inadequate empiric therapy rates increase with rising levels of antimicrobial resistance. And so this is a correlation, not necessarily causation, but it is an indictment on how misused antimicrobials are and what the potential downstream ramifications can be. Inadequate empiric therapy rates are higher and highest in SARS-CoV-2 positive admissions. So again, clinicians erring on the side of caution perhaps during the beginning of the pandemic, but overusing antimicrobials overall in retrospect. The respiratory source versus a blood culture or a urine culture in the hospital onset timeframe, so day 3 or later of the hospitalization, had higher inadequate empiric therapy coverage for antimicrobials. And so having these insights may help with diagnostic and antimicrobial stewardship and better selection of your empiric therapy and maybe faster selection of definitive therapy and more appropriate use of diagnostics. There are a lot of diagnostic tests available that clinicians don't use in order to, molecular diagnostics is a good example, in order to find out what the potential pathogen might be and help either pare down or even in some cases increase what your empiric therapy is. I mean, it all depends on that one patient in front of you and synthesizing the physical exam, the imaging, and the tests involved. And so the advocating of diagnostics can err on the side of doing less testing, or it can err on the side of doing more testing up front, depending on the case. But the more important thing is getting the most appropriate antimicrobial on for that patient. So in summary, the benefits of aggregate patient level data insights, and I'll add in near real time, is that what we found overall is that antimicrobial resistance and antimicrobial use both increase and correlate with influenza surges and COVID-19 surges. And this has potential hospital operational practices and resource optimization implications. If predictably over time, we know that H3N2 causes more severe influenza and higher hospitalizations, and that COVID Delta strain or X strain in the future causes more severe diseases and in particular age brackets, then we might be able to better resource our hospitals with the correct medications, correct par levels of medications so we don't run out, and then hospital resources like person power, because those were all issues when we were caught off guard with this brand new pandemic. The second insight is that higher incidence of hospital onset gram-negative and gram-positive bacterial pathogens had worse outcomes in COVID-19 patients. And how do we balance empiric with definitive therapy? And what are the role of appropriate diagnostics in delineating what that definitive therapy is? Thirdly, laboratory markers of end organ dysfunction can inform COVID-19 related hospital and public policy. And it doesn't have to just be COVID-19. I'd say practicing in the last 20 years, it seems like every 5 years there's a respiratory epidemic or pandemic threat, whether it's H1N1, pertussis, the other SARS-1, I'll say, and then MERS. And so SARS-CoV-2 is just the latest. And if we can marry sort of what happens when someone's admitted, and you saw the other slide where we had markers of myocardial inflammation, renal dysfunction, liver inflammation, different levels of potential sepsis, if we can sort of quantify per pathogen and per strain, as with COVID, then the dialogue broadens from, oh, we're just getting this many admissions. Well, maybe 4% of the current strain has admissions, but what if they're causing end organ inflammation and damage versus another strain that has 10% admissions, but very few are ICU, and they're causing very little end organ disease. Your public policy on masking might change, and your hospital policies might change. And so it's important to know the distinction between stats on hospitalization and actually what happens in a hospital, because the severity of illness does matter. Inadequate antibiotic therapy is consequential, and we saw this in COVID-19 emissions. And the higher length of stay and mortality is something that we hope to address potentially through the already existing infrastructure of antimicrobial stewardship programs and the sheer number of ID pharmacists that have sort of occurred since antimicrobial stewardship has become on the radar of the Joint Commission and CMS licensing auditing surveys. And so we think utilizing an already established infrastructure is probably the best way to go. Unfortunately, we've heard throughout the pandemic that stewardship programs and infection prevention programs were defunded or FTEs reallocated because of surge capacity. And so what this data also shows is probably during an infectious disease pandemic is not the time to defund your stewardship and infection prevention programs. Finally, electronically updated regional data may inform stewardship and infection prevention efforts. What's circulating in your community might give you the heads up of person power, staffing, to par levels of certain medications you know correlate with that particular pathogen. Research and development of vaccine campaigns. So if I were a vaccine maker, where would you want to deploy your vaccines? Would it be in communities that are preferentially affected by mortality, as our data have shown, geographic areas where you know that their socioeconomic income is of a certain level? How does this type of data help inform better management of the resources that we have in this country to address the social determinants of health? Clinical operational expectations and planning. So what some of you might not know is that after every cold and flu season, hospitals prepare for the next one. And it all has to do with the timing of hiring per diems, what agency you use, when do you want to pull that lever. And so if we had a collation of years worth of data of cold and flu surges and now COVID surges, maybe that planning can be a little bit more accurate and we have less surge capacity and bed issues. And then finally, geographic specific hospital resourcing, knowing what occurs in your geography and therefore your patient case mix is important because we are in such a large country. You should know the pathogens and the strains that occur in and around the community that you serve. So with that, I'd like to thank you, Kevin, for allowing us to present, and we'll take any questions that you might have.